Can I have your attention, please? Thank you. I want to welcome everybody here. My name is Jerry Chalman. I'm current chair of the Minnesota Citizens Federation. Our goal
How you doing?
with the Minnesota Citizens Federation in cooperation with our partners around the state is to work and hope that Minnesota becomes one of the earlier states to adopt some broad idea of the single-payer idea. We're pursuing currently a three-pronged approach along with our allies to do that. We're holding accountable the HMOs and insurance industry to utilize their funds for direct services and not for other things. We're promoting the expansion of county-based services throughout Minnesota. Several states or several counties in Minnesota do have county-based services. And we're working with our allies to see that that's expanded, and we've hired staff for that. And we're also working with others to see about a rational implementation of the Affordable Care Act and help the Affordable Care Act move towards a broader coverage and broader expansion. We welcome the members that are already here, and we welcome those of you who haven't yet joined. We're a member organization. We survive through our membership fees and some grants. If you're not already a member, you can become a member for $20. If any of you have the inclination, we encourage you to make further donations at the on the table are baskets looking for donations, whatever amount fits for you. I'd like to now briefly introduce our staff director, Buddy Robinson, without whom we would not be anywhere where we are. Buddy's knowledge of healthcare reform, and his commitment to making a difference is pretty much legendary amongst those of us that have worked with him, and I'm proud to work with him very much. And Buddy?
Thanks, Jerry. And one thing for folks who aren't familiar with our organization, it has been around since 1975, originally known as the Senior Coalition and then the Senior Federation. So this is actually the same organization, in case you were wondering. A couple of housekeeping things, just to be clear. The silent auction is being tallied up. At 8 o'clock, people who will be able to find out what they won and to pay up and to take their items. If someone has to leave before they can do that, they can call. We have your phone number, hopefully on the bid sheet. We can call you and you can retrieve the item at our office. The other thing is that we've advertised sort of this forum to go until 8 o'clock, but we'll be in question and answer mode with Dr. Kennedy, and depending upon people's interest and his willingness or endurance, we can continue past that, perhaps up to as much as 8:30. But if the discussion is still going on and someone wants to leave at 8, then please, by all means, feel free to do so. No questions asked about that. We're very happy to have Dr. Kennedy here. We think we can learn a whole lot from what Canada does and how it got their system, and we think it's a very important part of what we need to learn in our country, as well as combating the misinformation about Canada, which is one of the obstacles to having affordable health care and good reform in our country. So I'll give it back to Jerry.
Well, I've just had the pleasure for the last half hour of getting to know Dr. Kennedy a little bit, and I'd like to introduce you by telling that he's a family physician and the current executive vice president for medical, academic, and pharmacy services at the Thunder Bay Regional Health Science Center. Dr. Kennedy is on the board of the Canadian Medical Association, and he's past president of the Ontario Medical Association. And after his talk and his presentation, he will answer any questions. Thank you, Dr. Kennedy.
So thank you very much for inviting me here. It came in a strange way. I'm also an assistant professor of our new medical school, the Ontario School of Medicine. And my dean said emailed me after getting an email from from Buddy, saying who would be interested in this mic isn't quite working, so I do like to walk and talk. So so who would be interested in sort of coming down to give a little brief to our American counterparts? And when I was president of the Ontario Medical Association, that represents 25,000 physicians several years ago, that's when I became somewhat interested in the differences between the American and the Canadian healthcare system. And what I was really concerned about was the misinformation that was coming across about the Canadian healthcare system and how they were. I've got a pretty loud voice. Can everybody hear me that way? No, okay. So I guess it's not loud. My wife says it's loud. I guess it's not that loud. So I'll keep on. Maybe I'll stand still. Maybe the mic will help if I stand still. So it was really upsetting to represent 24,000 physicians in one of the best healthcare systems in the world, to have all this rhetoric coming across about death panels, coming across about long waiting lists, coming across about people dying in our emergency departments, and it was so frustrating. That's when we sort of got interested in trying to put a few slides together and really trying to decipher the myths versus the facts. And that's what I'm going to talk about a little bit tonight is the myths versus the facts. And I hope you can take away something from what I'm going to say tonight, because the Canadian healthcare system, it's not perfect. I mean, it's certainly not perfect. But seeing the gaps we see in the American healthcare system, it certainly goes a long way to address some of the inequalities that we see here in the United States. And you're going to see some of the data that actually proves that. So certainly I will take questions at the end, and certainly I'll stick around as long as I can. My wife's shopping at the mall right now. I do pick her up at some point in time.
Remote is conflicting with your mic. They could be feeding off each other.
Oh, that's right. Maybe I'll just use this slide over here and do that way. Thank you very much. So, so I am a family physician. I practice in, I guess not, nice try. I practice in Thunder Bay, but I work as an executive vice president at the regional hospital. And there I'm in charge of medicine and academics, and also go back where I was.
We can also try one other thing. So the only trick then is you need to not get too close to the speaker.
Okay, maybe I'll keep going when you try that. So my role is at the Thunder Regional Hospital is really take care of patient care, take care of the pharmacy, and to make sure that the system is working well. And we're really made some great strides in Thunder Bay to actually try to link the systems together. Right now, when I see many healthcare systems, it's not a system of care. It's individual practitioners, individual clinics, individual HMOs, and there's no system of care. The nurse practitioners do their thing, so physician assistants do their things, and there's no connectivity. And to deliver great medical care, you need to be connected to a system. You need to all be following the same rules. You need to be trying for quality initiatives. You really following guidelines, so you get the same care to the same patient at the right time in the right place. And that's the key to any healthcare system. And we're making a lot of road to try to move that in the right direction. So what I'm going to do is see if my slides work here. So in my previous slide, that is the slide, you're right.
Well, you can try this one.
Okay. Let's see, I'll go this way. Can you hear me now? Can you hear me? In my previous life, I was the chief negotiator at the Ontario Medical Association for 24,000 physicians. And that's when I really got interested in changing the system. In 2003, we had a net exodus of physicians to the United States and actually to other places in the world. Physicians were leaving Canada. We had 22% of our family doctors going into, from our medical students, going into family practice. And we need to have that moved up to 44 or 45%. So we took the initiative to sit down with the Ministry of Health, who is our single payer. And I'll get to that point in a minute. It's not really a single payer we have in Canada. And I think you got to get off that premise of a single payer. Because a single payer You want a single payer for the basic necessities of health, because that's affordable. Once you go for a single payer for everything else, for dentistry, optometry, for psychological services, for plastic surgeries, it's not affordable. But a single payer for the basic necessities of health care is definitely affordable, as you're going to see in a little while. So that's what we're going to sort of concentrate on as we move forward. But it's really an exercise that was part of the most exciting period of my life, where we sat down with the Ministry of Health, said we needed to change primary care, the way primary care was going. And our Ministry of Health, they were sort of concerned. We as physicians of Ontario were concerned. And you're going to see some slides later how we actually changed the direction of primary care physicians. So now we have 44% of our medical students going into primary care, and we certainly have stabilized primary care in Ontario, where now is the specialty of sort of desire for most of our medical students now. So because we're able to see a problem and address that problem. Now we have more physicians coming from the States into Canada than leaving. And that's the first time in about 20 years, actually. So we have a net entry from the United States, and United States graduates, Canadian graduates. So this is very, very positive over the past, and that's just happened over the past 3 or 4 years. So what I'm going to talk about here is this is my outline of what I'm talking. I'm going to talk about the Canadian population. I'm going to talk about do we really have a universal single-payer healthcare system in Ontario, and I'm going to talk about the private versus public, because we're not all public funded. We have significant private funding in Ontario also. And then I'm going to talk about certain myths, and there's more myths than these. These are the ones we highlighted over the past several months. But certainly, a single-payer, publicly funded healthcare system is more costly. We're going to destroy that myth tonight, because it's not more costly. We're going to have longer waiters in Canada can lead to poor health outcomes. Again, that is not true. We're going to talk about the medical malpractice insurance costs are trivial for Canadian MDs. It's not trivial, but we have somebody else pay for it because it's part of practice. We're going to talk about the publicly funded healthcare system results in lower MD incomes, and you're going to be quite surprised that we're quite competitive and comparable to the United States. We're also going to talk about the healthcare system can attract enough MDs, and we're going to look at some numbers that we can attract enough MDs to stay in our system. We're also going to talk about that Ontario is the leading primary care innovation in North America, and we're going to see some numbers on that and how we transform primary care in Ontario.
Dr. Kennedy, do you have a printout of any of this?
What I can do, you can copy the slides at some point in time, Buddy.
Yeah, we can provide the PowerPoint slides.
Buddy has the slides, so you're welcome to that. So Canada's population is just over 33 million. That's 1/10 the size of the United States. Ontario's population is 13 million, and we have 24,000 active physicians practicing in Ontario at this point in time. Those numbers are important. Those numbers are important because here's the population of the United States. What's the population of Minnesota?
5 million.
5 million. Okay. So that's where we took Pennsylvania, because Pennsylvania is 12 million. It's a similar size in Ontario. That's where we took those two populations. And we have, so we had 24,000 physicians in Ontario. They have 36,000 active physicians in Pennsylvania for the same amount of patients. So that's right now. So you have a third more physicians in Pennsylvania for the same patient population. This is a very interesting slide, and I'm not an economist. I work with a lot of economists, but I'm not an economist. But right now, this is, Canada gets abused saying they don't pay enough for their health care. But basically, the United States pays a lot for their health care, and it's certainly not, and it's not universal. But Canada pays quite a bit of money for their health care also. But you can see, surprisingly, that Canadian health care pays per capita. This is per capita. Adjusted for the difference in cost of living, our public's $2,863, and that's publicly funded dollars. The United States pays more. They pay $3,500 per capita in their public funds. So where is the discrepancy? Because right now they don't cover 100% of the patients. They only cover about 80% are publicly funded in the United States. So there's a big gap. There's about 16 to 18% of patients, the population in the United States, that have no health insurance whatsoever. In Canada, 100% of our patients, of our population, are funded by our public system. But what's interesting too is that we also have private payers. We actually will pay the basic needs of the health care to all populations, and that's there's no gaps. If you have a problem, a broken leg, a baby is sick in the middle of the night, you will come to either your private physician or you will come to the emergency department. No one will be turned away in Canada for health care because of the affordability. No one at all will be turned away. Many Americans will come to use our system. They're surprised that they're not even billed at times for their services, because the physicians have that social accountability in the sense they really have. In 1963, Tommy Douglas got this movement going in Saskatchewan. Then we introduced the hospital portion and then the physician portion, and that was a social movement that actually transformed Canada, and it transformed a lot of times the meaning of Canada, because that's how Canadians, when you ask Canadians what they pride themselves in, number one, hockey. It actually is just catching up to them, and the healthcare system. That's what they pride themselves in. But again, it's not totally publicly funded. 70% is public, 30% is private. So there's still private dollars that have to go into it to sustain the system. And then there's also the payer pays at some point in time in small areas. So the total expenditure, comparing the Canadian and American health expenditures, in Canada, publicly, we spend $4,196. That's the total expenditures. That's public, private, and payer. United States, boy, almost a third more, 7,410, again, per capita. But again, they're not all covered. Ours is based on 100% coverage. The United States is based on about 80% coverage, and a lot more expensive when you access some of the diagnostics in the United States. So 10.9 of our GDP spent in Canada, 16.2. So now our system, as we move forward, is not affordable. We need to change a lot of areas in Ontario to sustain the system. We need to correct a lot of our areas in Ontario, and that's just 10.9. Your system, at 16.2, is also not affordable, and it's not very efficient either. So again, I'm not promoting Ontario as the best healthcare system in the world. It's very good, but we need to keep on. But you're going to see, as I go through the slides, how we actually looked at a problem, corrected the problem, moved on. Looked at another problem, corrected it, moved on. So that's the nicety, the beauty of the system. We look at a problem, we get together with the government, we get together with the physicians, get together with the hospital, we sit down and say, we have a problem here, let's address it together. And who values from that system? The patients and the population. And then that is the perfect solution. Next slide. Now this is a very interesting slide when we put it together. So the life expectancy at birth. So you would think if you're spending that much on your healthcare system, you should have better outcomes. Now we don't measure outcomes very well in the world actually, but one of our outcomes we do measure is the life expectancy at birth. In Canada, in the male population, you have a life expectancy of 79, female 83. United States, 3 years less, 76, and the female 2 years less, 81. The probability of dying under 5 in Canada is 6 out of 1,000. In the United States is 8 out of 1,000. We have problems in Canada with rural sort of practice, with First Nations practice, where their ideology about healthcare is not the same as many, so they may not seek the healthcare of a physician or a nurse practitioner. So we do have problems in the First Nations area. We do have problems in rural medicine. That's why ours is probably, I think ours is about 8th or 9th in the world. So still we have a lot of room to improve also in Canada. But this is a very interesting one right here, is the probability of dying between 15 and 60 years of age, male and female. So in Canada, 87 out of 1,000 males will die between 15 and 60. Females, 53 out of 1,000. But look at that in the United States, 134 of a population of 1,000 will die in between 15 and 60 in the United States, and also 78 out of 1,000. Those numbers are dramatic, actually, when you see that. And why is that? I think there's a number of scenarios. I think the lack of sometimes immunization access in the United States is in a free immunization system in Canada compared to the United States. Certainly, I think violence certainly it has a major effect in that population. But certainly there's many factors. But that's one of the outcomes that are striking when you see these numbers. So this is back in 1963. It's been edited. It's been adapted. But certainly this is the pride of Canada. This is the Canadian Health Act, and this is a federal act. Now, I think if you're going to win the one-payer system in the United States, it's got to be sort of led by the federal government, but I think it's got to be implemented by your states, your local states. And that's what we did in Canada. So we had the Canadian Health Act, who in 1963 sat down, and but we had a socialist government. We had at that time, we had Tommy Douglas in Saskatchewan for NDP, who was a leader. He was a champion. He knew things had to be done. Now 1963 is different than 2013. The taxes weren't as high already. There wasn't as many diagnostic tools. The healthcare system was not that expensive, so it was easier doing in 63, but they had the wisdom and the foresight to put this plan together. And it was initiated by our NDP government in Saskatchewan and moved forward to our Liberal government by Lester Pearson in 1964. Initially, we went with hospitals. So everybody who went into the hospital in 1964 under this Canada Health Act, it was covered. Because what's happened before, you'd go in, some would get covered, some wouldn't get covered, and it really, I think this took on a lot of social responsibility. This was moving forward. You had to move the culture. This moved the culture. This moved the culture that Canadians take care of Canadians in the way they should, regardless of the affordability. So this Canada Health Act was a key to moving this system forward. 2 years later, or 3 years later, 1967, that's when physicians were paid, and that was almost a riot in Saskatchewan. I mean, and when the physicians did not want to go to a single-payer system, they obstructed it. But there's a number of leaders at the time that this is the right thing to do, and they never look back. Physicians are very happy in that single-payer system. They have to do, they really take care of each other in that single-payer system. And there's lots of discrepancies. I mean, you can still make $1 million in Canada as a doctor if you work hard, because there's also incentives. But you're still taking care of each other, and you're taking care of the patient. So what happens here is to protect, promote, restore the physical and mental well-being of residents of Canada, to facilitate reasonable access to health services without financial or other barriers. Now, the key for that being Canada, because it also has universality, all medical care and hospital care is covered to a certain extent, the necessities, but also if you go from BC to Ontario to Newfoundland, it's portable. You will be covered, and that's the key. Throughout Canada, you will be covered. It's called portability and universality. Those are the two key components of that. And ensures that all residents will have access to medically necessary hospital and physician care. Now, the key we always struggle with is medically necessary, and that's what you're going to have your big struggle here. I mean, what's medically necessary and what's not? Determine those procedures that really determine the outcome of health, and you really have to sit down. We're struggling with that also. I mean, initially we had plastic surgery covered. Initially we had, there was psychological services covered. We had a whole gamut covered. We've had to claw back a bit for the affordability. So now we still, cover the medical necessity health care that's required to improve your health outcomes. But psychological services, eyeglasses, dental wear, some medications are not covered. So we struggle with that at times, but still, I think it has not affected the health outcomes of Canadians. Next slide. So again, this is what is medically necessary. This is the private versus the public funding in Canada. So 27.4% of healthcare is paid through the private sector. So again, it's not a single payer. It's a single payer for 70% of our medical necessity, but it's not a single payer for other areas. 75% of our Canadians have other health insurance to cover for other services like eyeglasses, dentistry, as I said, so that medication. So we do have payers, insurance payers, and most of the employers and who have access, but we also have something called the Trillium Drug Act, is that if you're not employed, if you have high expenses for drugs, there's a minimum amount you will pay, sometimes $100 to $200. The rest of your drugs will be paid for. And that's important because some of our new drugs out there, our chemotherapy drugs, our sort of our rheumatological drugs, they can cost $24,000 to $25,000 a year. They can cost $3,000 to $4,000 a month. And we won't hold that back if it's signed off by a physician. If they follow the guidelines, they will be actually covered, but with a small fee because if they can't afford it through a Trillium Drug Act. So even though the drugs are not covered in the majority of the population, we'll find a way to cover many of those expensive drugs if it has a positive outcome and they're following clinical guidelines. Next slide, please. So private funding in the United States. So again, as you all know, I don't have to tell you that it lacks universal coverage for everyone. 16.7% of Americans are without health insurance, or in absolute terms, and these are 2010 numbers, I think, 50.7 million of you do not have universal health coverage, don't have health coverage. And again, this is, and I'm not going to quote the American legislation going on right now because I know very little about it. I got a question from when I started my talk. It said, "How many Americans how often do you get this talk, Dr. Kennedy? How many Americans do you talk to?" And this is my first audience of Americans. I go to talk to a lot of Canadians, but this talk I'm giving tonight, I've never given before. So because we prepared it when I was president, I refined it, but it's special for myself, but I've never had the opportunity to give it to a group of Americans, and Canadians are really interested because it's really based on an American audience to actually because of all the bashing that was going on with the Canadian healthcare system. But I'm going to refine it as time goes on, and if I get any more invitations, I may refine it even further and start talking about all the equality acts we have in Canada moving forward. But as you know, the regulatory reform of the American healthcare system, the Patient Protection and Affordability Care Act, it passed the House in October 2009, passed the Senate with amendments. House agreed to Senate amendments, and now, as you know, right now, you just have a stalemate. I think they're just talking, but there's no action, and I think there's no leadership. I really think you have a bomb out there, but I think there's no leadership to take up all the falsities out there. I think what you need is strong leadership, which you're getting in these small groups, but you actually need some leaders to take on many of the falsities out there, actually, because what they get away with, I'm sitting in front of my television in Toronto sometimes in front of me, what they get away with is many times pure lies, pure fear-mongering with what they do there, and then when they start bashing the Canadian system, that's when I sort of start getting a little bit upset myself, actually. Next slide. So here's the myth. A single-payer, publicly funded healthcare system is more costly. As you said, we've seen earlier, $4,000 per capita, $7,000 to $8,000 per capita in the United States. I mean, it's not more costly whatsoever, in fact, and it's much more cost-efficient to have a single payer. The broad consensus that the administrative costs in the United States healthcare system are unnecessarily high. Money that could be going for patient care is going to insurance companies, is going to bureaucracy, to do paperwork, fill out forms. I mean, I get enough forms in my office. I cannot imagine how many forms the physicians, the healthcare workers in the United States get. I mean, I take care of, my roster is about 3,000 patients. I have one secretary. And that's it. So my costs are probably 20% is overhead cost for me.
In the United States, I suspect it's probably 50% of the overhead cost, if not more. So I mean, and that cost, you know, is from our perspective, could be going to patient care. It would not be going to bureaucrats. So practices are forced to interact with several healthcare insurers. We just interact with one insurer, one payer. I submit my bills on a daily basis, and we get 100%. Well, I can't say we get almost 100% of our bills refunded, you know, by the ministry. Certainly, there's sometimes we don't have up-to-date coverage. We don't get total, you know, coverage, total sort of payment of that. But really, 99% of our bills, we don't have any bad debts whatsoever. The hospitals do not have any bad debts. So I mean, everything is funded, and so when the physician puts a bill, you will get paid for that bill. You know what your account's going to be. You know you're going to be accountable to the your banker each and every month, and you know what's coming in. Same with the hospitals. Hospitals submit a bill. They will get paid for by a single payer system, so they can predict their budget. Many times you can't predict your budget in the United States because about the bad debts, which again leads to unpredictability. What service you're going to deliver next tomorrow because you may not have funding to deliver that service. Next one, please. Several studies, you know, a single payer again, several studies support this inclusion. In 2006, physician practices in Ontario spent $22,000 on average per physician on administrative costs, plus 2.5 hours a week of a physician practice. Here in the United States, 82,000, 4 times as much on administration cost than in Canada, and 5 times, 10 times as much on the physician's work in the office has gone to administration work instead of seeing patients where they can see patients and have a positive outcome. That to me is a misuse of resources when you compare the two systems. 2002, Canada spent $15.89 per capita less on physicians and hospitals than the United States. Administration accounted for the largest share, 39% of the difference in that. 31% also came into for intensive provision of medical services, 14%. So incomes, 31%, but 39% was administration costs. That is again a waste in the system. Yes.
You have to submit a bill for everything you do.
Yes.
Don't you think it would be better to have a system that eliminated that?
We'll get that to the end, but I'll just answer this one question. So, what happens is the fee for service in the United States, in Canada and Ontario, we think a blended system is better. So in the IE, you get a certain amount to take care of a certain population base called capitation, but you still want to motivate the physician to get out of bed at 2 in the morning. You still want to motivate the physician to get out of bed and work in a group at 8 o'clock at night. So a blended system that is capitation, which is like a salary-based, as well as a fee-for-service to motivate and also make that physician accountable so we can follow how many patients he or she is seeing. If they get a pure salary model, our research demonstrates actually that the service volume goes down, the service delivery goes down. So we need to actually track, make the physician more accountable in a salary-based model, and that's why you get a blended system, both salary and fee-for-service. We think is the best fix for both the patient and also for making the physician accountable to the delivery of services. Because too much salary leads to, in some populations, laziness and also a lack of delivery of the service that the patient needs.
Capitation for those 3,000 patients on your roster.
I do.
That's a fixed amount.
That's a fixed amount, but anyway, we'll get into that when I get to the primary care too. So in 1989, again, administration accounted for 31% of the total healthcare spending in the United States compared to 16.7% in Canada. So as you can see, there's a lot of waste in the system, and there's still a lot of waste in our system. But certainly you need a lot of catching up, and those dollars could be going to serving patients. Next slide. This is the one that really irritates me when I hear it here on on the news that wait lists in Canada lead to poor health outcomes. So in Canada there are no wait lists for urgent or primary care in Canada. In fact, we have here's a survey that was done on some measures of accessibility. Canada outperforms the United States. So the survey was done. somewhat or very difficult to get care on nights or weekends without going to ER. And 54% of Canadians said yes, it's somewhat difficult. 61% of the United States said it's difficult. And that's in a system that has supposed to have great access to care. Primary care practices that have an arrangement where patients can be seen by a doctor or nurse if needed when the practice is closed, not including the ER. 47% of practices, you can actually have evening hours in the United States, and only 40% in the United States. So we have better access to many of our primary cares and pay less than the United States system. So certainly, next slide, more of the wait list. So we realized about 6 to 8 years ago that wait lists were a problem. Wait lists were a problem for MRIs, CAT scans, cataracts, CT scans, which I said already, hip surgery, angioplasty surgery. We realized, we tracked it, and we said, you know what? Many of our patients are going down to Duluth to get their angioplasty, to get some cardiac bypass surgery. They're accessing the medical services in Duluth. We tracked all that because we actually Ontario government would pay money in particular circumstances to fund that. So we tracked all that and we said, we have a problem. Went to the federal government. The federal government made all provinces sign on to this wait list strategy. And they gave extra funds to deal with the CAT scans, to deal with the wait list with orthopedic surgery, with cataracts. Next slide. And this was the result. We actually had a problem, addressed the problem, and now the wait list for cancer surgery is down by 22%. Wait list for angiograph down by 51% decrease. Wait list for cataract surgery down 61%, 189 days. Hip replacement down 53%. So yeah, we still have wait lists, but we have no wait lists for any significant priorities. And we have, for hip surgery, it's probably about 2 months at this point in time, not 16 years as other people let you believe. Next slide. So again, if you have significant problems, if you have heart disease, if you have cancer, you'll get seen immediately and you'll be placed in a queue and you'll get your things done within 2 weeks. I mean, some cancer surgeries are a bit longer because we make a decision with the attending surgeon, attending primary care doctor, that there's other priorities and that this one can wait. That to get cavity surgery, the median wait is just 16 days. That's a triple bypass, quadruple bypass, 16 days wait in Canada from time of diagnosis to time of going for surgery. Diagnostic cardiac for catheterization to see what's going on, median wait 10 days. And there's no people are dying in the hallways waiting for service. An angiogram where you put a catheter through up the groin or into the arm, through the heart, you sort of expand the blocked artery. Again, median wait time 2 days from time of diagnosis. I mean, to have that median wait of 2, most people are getting it done in probably 2 or 3 hours. I mean, some may have to wait 4 days if they're in rural Ontario and have to travel a bit. But the care, so I guess the care, what I'm saying is, we look at the data, we say where we need to put our resources, we put the resources in those areas. And that is, the more data we're tracking now, the more detail we're getting with our diagnostic codes and so our sort of wait list strategy, and our IT technology has really made strides over the past 4 or 5 years that we can actually intervene in the problem, put some money at it, and fix it. Next slide. Myth number 3, medical malpractice insurance costs are trivial for Canadian MDs. We pay significant malpractice insurance, being physicians, because we get sued just everybody gets sued. I mean, that's part of the risk of practicing medicine. We're not perfect, and things happen that are, sometimes we actually made an error, or sometimes just things happen and with the health, and certainly, so we have to be protected. But certainly, so the doctors receive malpractice protection, and we have the Canadian Medical Protective Association. One insurance company covers physicians throughout Canada. And so they can actually negotiate good fees with the lawyers, and they can actually negotiate good outcomes when you go to court. I'll explain that in a few minutes, actually. Next slide. So in Ontario, the obstetrician pays the highest annual fee, about $70,000. Of course, that compares to Southeast Florida, they pay $200,000 annually. And those costs have to be absorbed someplace. So the more that physician has to pay, the more it's going to come back to you as patients and insurance companies. So I mean, you're paying for that. Certainly, but the physician in Ontario only has $5,000 out-of-pocket expenses. That is total. The government pays the rest for in Ontario. So again, it's not totally coming out directly out of patients' pockets. Next slide. What's very interesting though is the number of malpractice lawsuits in Canada have dropped since 1996. And this is all Canada. This is, I think 60,000 physicians. There's only 1,415 lawsuits were filed in 1996. And there's less than 2004, just over 1,000 lawsuits, a 23% decrease. Why is that happening? First off, the ones that are going to court are getting bigger awards. So the awards are going to court because the ones going to court, making the courts, there is definitely malpractice involved. Our Canadian Medical Malpractice Association, we have the best lawyers, the top lawyers in the country, in the world. So when a private lawyer takes on the CMPA, CMPA will actually only take something to court if they think they can win it. So once they find they're going to go to court, many of the lawyers have dropped it because they know they don't have a good action. So from our perspective, we have tough lawyers who will defend us for frivolous complaints. But if the physician has made an error, our lawyers will settle out of court and give the patient, give the family what they deserve because we messed up. And so, but the system works. One Canadian Medical Protective Association is cheaper, there's less lawsuits, and it's certainly, in the United States, I mean, there's so much protective diagnostics, there's so much protective sort of practice of medicine going on to prevent a lawsuit. And these all create costs. So at some point in time, I think we all, both Canada and the United States, have to look at tort reform, where there's a certain amount of money paid for each case based on a formula. But that's a long way off even Canada. But that would actually do a long way to decrease the amount of malpractice in the United States. Next slide. So again, another one, a publicly funded healthcare system results in lower MD income. So this is old data. This is 2009, 2010, and I know we've all had one negotiation since that time. But this is on average. A GP in Canada can make $186,000. A GP in the United States, $217,000. Now that's average, and that's net income. You have opportunity if you increase your volume of practice. You can make a lot more than that, and the same thing in the United States. But those are average incomes. But the discrepancy is not that great, based on what other sort of areas that you compare it to. So the discrepancy we think is quite comparable, and the opportunity, as I said before. Like orthopedic surgery, most of my colleagues in Thunder Bay are making over $500,000. I mean, they just work hard. In family practice and underserviced areas, they're making $500,000. I mean, so it's not all about income. It's also about accessibility to care, actually, too. So I mean, but again, these are average. It's not as sort of dramatic change as there once was. Next slide. So until 2005, the medical profession, and we still think it is, was a top earning trade relative to other professions in Canada. More than lawyers, more than accountants, certainly. So medicine in Canada is still the best paid profession in Canada. And I don't think anybody else has replaced that at this point in time. Maybe bankers, but I'm not quite sure. Now this is where it's interesting. I'll get some more slides later. It's about primary care reform. But over 80% of our Ontario physicians practice in either a family health network called a FIN or a family health organization. This is all based on a capitated model. Maybe I'll talk a bit about it now. Prior to 2003, primary care doctors got paid fee for service. They saw a patient, billed the government, they got paid fee for service. But we were being drained. The family practitioners to actually earn a respectable income, we're burning out. They're on the treadmill. They're putting 50 and 60 patients through at a time. Patients weren't getting good care. Physicians were feeling burnt out. Family practice was not being chosen by medical students anymore because of the view that they got to just work too hard to make an income. So we saw this, again, this is one of our corrections we made. We saw this in 2003. I was sort of led the negotiating in 2003, sat down with the ministry, and said, we have a problem in family practice. If we don't actually generate some more family practitioners and primary care workers in the field of medicine, we're going for a crisis in primary care. And once primary care goes to the crisis, which is the stability of health care in the world, then certainly the expense will go up because specialty care is just that more expensive than primary care. And access will falter. So we made a conscious decision to change the system from a fee-for-service system to a capitated system. Meaning if patients roster with a primary care provider, they would get so much a year. And this will surprise you. So what a primary care doctor gets paid now to roster one patient as, say, an average age of 55 or 60, they get paid $140 a year to take care of their total needs. And you wonder, well, how can that physician make it an income? Well, you change the way you practice. So in a sense, so you roster more patients, but how many patients really need to see the primary care doctor for prescription renewal? How many really has to see for a sort of a sore foot? How many really has to see for a drug change? How many has to see for a blood pressure? So you hire a nurse practitioner. You actually hire a primary care nurse. You actually will make a phone call and see how they're doing or sometimes you make a house call. So basically we change the way we practice medicine, and we don't have to see them every single, once a month or once every 2 months. We actually pick up the phone, talk to them. So we change their style of medicine, and now even though you can pay $140, dollars, that's on average based on age and sex. Physicians' incomes have gone up 50%. And physicians now in primary care, 80% are happy to practice primary care. 45% of now medical students are going into primary care. We made a significant shift, and we changed the culture of family practice. Now, when I first went out on the road and tried to sell this story to 24,000 physicians in Ontario, I wasn't well liked. I mean, I had a lot of anchor physicians. The first contract was turned down by about 50%, 65% turned it down. We kept at it. We said this is the right thing to do. We said this is the right thing for patients. This is the right thing for the cost of the healthcare system. And probably 6 or 8 months later, another vote, and we got overwhelming acceptance because they understood it. It was such a momentum shift. They understood it. And again, so that's where we identified a problem with the data we had. And we looked at things. We had a cooperative partnership with the Ministry of Health, a cooperative partnership with physicians, and we changed it. And that system works. Now, this is not only capitation, as I said before, it's a combination of capitation and fee-for-service, because again, there's a partial fee-for-service that gets people doing special things to enhance the quality of care. They get bonuses for doing preventive care, for looking at colonoscopies, stool for occult blood, looking at immunizations. They get bonuses along the way. So if you really practice medicine the way it should be practiced, based on quality and based on health outcomes, it's an improvement in the healthcare system, it's an improvement in health outcomes for patients, and it's better for the patients. Next slide. So another sort of myth is physicians in Canada and the United States, again, density per 1,000 population. As you can see earlier, that in 2004, we were just holding our own. We had one of the lowest patient population, physician patient population in the world. I think it was about 1 in 1,700, something of that nature. But as we changed the system of care, as we actually said, paid our physicians more money, made them more accountable to certain aspects of the system, and improved their quality of life, which is so important. We saw a drift from the United States physicians coming to Canada, international IMG graduates from international schools coming to Canada, and now we have the same patient population density as the United States because we made that shift. Made that shift in culture. We also made that shift as a single payer, and I think people were not burning out as much in Canada as they once were. Next slide. So here's just some average numbers. Number of active physicians, we actually increased to 24,000 in 2009, 2010. We also opened up a new medical school, the first medical school in Canada since 1971, and that was in Thunder Bay and Sudbury. So we have a new medical school in Thunder Bay again, and we also increased enrollment in the other medical schools throughout the country. So we knew we had a problem, so we increased enrollment, and we actually opened up another medical school. And a medical school that was real versed in rural medicine. So we're training physicians now who are not going to metropolitan Toronto, not going to the Hamiltons, the academic centers, but are being trained in Thunder Bay and Sudbury, and they're going up to the Northwest Territories, and they're going up to the First Nations, and they're going up to the smaller rural communities, and they're well versed to do it. They're skilled. They learned in a smaller community. They learned in a rural setting, and their graduating marks are just as good as the Toronto graduating marks and the other medical schools. So they're well trained, but they're confident going out practicing rural medicine on their own because they're connected. They're connected to a system of care. So they're connected to Thunder Bay Regional Hospital and our group of physicians there. And we can't have. They're connected to to Toronto. So what we're developing now in Thunder Bay is called quarters of service, where we have a major academic center who's the mother center. And if we have gaps in service, like we do in vascular service or cardiovascular, or if we have gaps in service in Dryden where they don't have orthopedics, we're connected. Okay? So they give the secondary, tertiary hospital a call, and we're obligated to take their call and help that physician out there. And if we can't deal, we go to the next center. So we're looking at connectivity, and I think is the way to move forward the whole healthcare system. And again, who values is the patient. Next slide. So there are increased number of domestic medical school graduates, as I said. Currently, we have 260 new first-year medical school spaces. That's a 38% increase since 2004. Now people are saying, are we graduating too many physicians? Because there is a thought out there that the more physicians you have, the more cost it is to the system. And they're correct. I mean, absolutely, so the more physicians you have, the more diagnostic tests are ordered, and the more cost to the system. And that's why the Americans' costs are so high, because their physician population density was high. So it's going to cost the system more money. But physicians, in my experience, work to a particular income, depending on their lifestyle. So many physicians will work to they're not going to see, the new physician coming out now, they're not going to see the 60, 70 patients in a day to make that income anymore. They're going to see, my roster maybe 3,000 is too much. The new physician coming out, they're going to roster about 1,000 patients, and they're going to take great care of those 1,000 patients. Unfortunately, there's still more